The last presentation is another controversial topic, the biomarkers. This NT-proBNP stratified long-term follow-up in outpatient heart failure clinics, a prospective randomized multicenter trial in Danish heart failure clinics network. Dr. Scott will present this information.
Dear Chairman, thank you for the presentation. Dear organizers, thank you for allowing me to present the North Star study, NT-proBNP stratified follow-up in outpatient heart failure clinics, a randomized Danish multicenter study. This is my disclosures. I will start to thank all the nurses and the cardiologists in the 18 heart failure clinics in the centers in Denmark, and the sponsors, Roche Diagnostics, MSD, and the Copenhagen Hospital Corporation for supporting this study. The introduction, the North Star study had 3 objectives: to determine the effectiveness of a continued heart failure clinic intervention, to determine whether NT-proBNP can identify a patient with particular benefit of a continued follow-up program, and finally, to determine if monitoring high-risk patients using NT-proBNP improves long-term clinical outcome. The population studied is predefined clinical stable systolic heart failure patients on optimal medical therapy, and the primary outcome is time to death or cardiovascular hospitalization. This slide illustrates the Danish heart failure clinic program. The GPs, the Echo Lab, and Department of Cardiology and Internal Medicine can refer the patient to the public heart failure clinics. 40 hospitals in Denmark have a public heart failure clinic. They are nurse-driven and cardiologist-supervised. There we determine the etiology of the heart failure disease. We educate the patients, refer them to exercise, up-titrate the patient in ACE inhibitors, beta blockers, and aldosterone receptor antagonists, adjusting doses of diuretics, implement CIT and ICD if indicated. Some patients remain unstable and then are referred to a tertiary center for LVAD or a heart transplant, but most patients become stable. And even they are clinically stable, poor long-term adherence and readmission is still a clinical problem. So we ask the question, where should these patients be followed? In Denmark, these patients were at that time followed by the GP, that was routine, but should they be followed in the heart failure clinic, or should only high-risk patients identified by NT-proBNP be followed in the heart failure clinic? We therefore launched the study with the following inclusion criteria: patient with chronic heart failure with a left ventricular ejection fraction below 0.45 and a functional class 1 to 3, and fulfill pre-specified criteria for stability. This is the stability criteria published in American Heart Journal. What they say, the patient should be educated, up-titrated in medication before entrance to the study, had an ICD or CIT implanted, stable functional class, and considered euvolemic. Then we had the following hypotheses. Clinical stable systolic heart failure patients on optimal medical therapy benefit from long-term follow-up in a heart failure clinic. That part of the study had a power of 80% to detect a difference of 25% at a significance level of 5%. Then we further hypothesized that this benefit is driven by an effect only in high-risk patients identified by NT-proBNP with NT-proBNP levels above 1,000, and this is a pre-specified interaction analysis. And then finally, we further hypothesized that high-risk patients identified by NT-proBNP above 1,000 benefit from NT-proBNP monitoring, and the present NT-proBNP monitoring concept should be considered as a proof of concept study. And the methods used, it was a probe design, prospective randomized open label blinded endpoint study. It was multicenter, 18 sites in Denmark, and it was investigator initiated. This slide illustrates the North Star intervention and the standard treatment performed. The intervention in the heart failure clinic consisted of management of comorbidity, adherence to guidelines, adjustment of diuretics, telephone service at daytime, and continued education. The patient visit the heart failure clinic with 1 to 3 month intervals at the discretion of the investigators. In the usual care, the GP received a discharge letter. The patient and the GP then arranged the follow-up program, and no training for the GPs in relation to the study were conducted. This slide illustrates the NT-proBNP monitoring intervention. At the left, we have the standard treatment again, and to the right, the heart failure clinic NT-proBNP monitoring. And NT-proBNP was then analyzed at each visit. If NT-proBNP increased more than 30%, completion of a clinical checklist was required, even the patient did not become more symptomatic. And it should therefore be noted that an NT-proBNP lowering strategy with drugs was not tested in the present study because we intended that the patient should be on optimal therapy before entrance to the study. This checklist is published as well in American Heart Journal in 2008, and basically the checklist evaluates the effects that might increase NT-proBNP, sodium intake, volume overload, QRS prolongation, new or fast AFib, increase in creatinine, or inappropriate doses of RAS blockade. This slide illustrates the randomization process. The patients fulfill the criteria for stability, then NT-proBNP is drawn, and if it's below 1,000, the patients are randomized 1-to-1 to either general practice or heart failure clinic standard follow-up. If NT-proBNP is above 1,000, the patient is randomized to either GP, heart failure clinic standard follow-up, or heart failure clinic NT-proBNP monitoring. And then we could compare the heart failure clinic versus general practice and perform the pre-specified interaction analysis, and we could compare clinical judgment versus NT-proBNP monitoring in the heart failure clinic. I'm now going to present the results. This slide illustrates the trial structure. 6,180 patients had at least one visit in one of the heart failure clinics in the randomization period. 1,640 patients were considered eligible, 520 were excluded, 1,120 patients were randomized, 460 patients allocated to GP, no one lost to follow-up, and 460 patients included in final analysis. And then 660 patients allocated to the heart failure clinic, and of those, 199 allocated to NT-proBNP monitoring. One informed consent was withdrawn, and therefore 659 patients were included in the final analysis. And the patients were followed for a median follow-up of 2.5 years with a range from 90 days to 4.5 years. Then the patient characteristics, and I'll now present the heart failure clinics versus general practice. All confounders were balanced and the patient matched. And the median age was 69 years, female, frequency 27, left ventricular ejection fraction 30, functional class 2 and 3 71%, NT-proBNP 800, and just below 90% of the patients were treated with ACE inhibitors and beta blockers. This is the next slide will present the heart failure clinic standard treatment versus heart failure clinic NT-proBNP monitoring. And again, the confounders were balanced and the patients were matched. They were 74 years old. Again, 24% were female sex and 30% left ventricular ejection fraction was 30%. And NT-proBNP was here 2,000, and just below 90% of the patients received ACE inhibitors and beta blockers. The next slide will illustrate the primary composite endpoint in the heart failure clinic versus general practice. This is a Kaplan-Meier curve of the primary composite endpoint, time to mortality or cardiovascular hospitalization. At the x-axis we have the days, and the blue line reflects the GP, and the black line reflects heart failure clinic. And there was no effect of the heart failure clinic intervention on the primary composite endpoint. This slide is the other main result. It reflects the NT-proBNP stratified hypothesis. The blue lines reflect follow-up in GP, and the black line reflect follow-up in the heart failure clinic. The two lower lines reflect patient with NT-proBNP levels above 1,000, and they had a higher event rate, and NT-proBNP identified the high-risk patients, but the heart failure clinic intervention failed to improve outcome for these patients. There were no significant interaction. And then the primary composite endpoint for the heart failure clinic standard treatment versus heart failure clinic NT-proBNP monitoring. And the black line reflects follow-up with the standard program in the heart failure clinic, and the red line reflects the NT-proBNP monitoring concept with the checklist. And there was no effect on the primary composite endpoint of NT-proBNP monitoring with the present NT-proBNP monitoring concept. Then to the secondary endpoints: time to death, time to a cardiovascular hospitalization, time to a heart failure hospitalization, time to an overall hospitalization, Minnesota Living Heart Failure Score, functional class, NT-proBNP, and patients admitted, number of admissions, and admission days. And for all comparisons, there was no significance. In the main study, heart failure clinic versus GP, in the NT-proBNP stratified hypothesis, and in the heart failure clinic versus NT-proBNP monitoring. And then to the conclusions. Clinical stable systolic heart failure patients on optimal medical therapy do not benefit from long-term follow-up in a heart failure clinic. A subgroup of high-risk patients identified by high NT-proBNP levels do not benefit from long-term follow-up in a heart failure clinic. And finally, the present NT-proBNP monitoring concept does not improve long-term clinical outcome. Thank you for your attention.